All right, welcome back, ladies and gentlemen. EM board bombs, emergency medicine board bombs. We tell you what you need to know for boards and life. You know who we are. Iltifat hates it when I do these intros because he's like, people should know by now, but I like to be polite for any newcomers. We got a special guest today. We got Haney with us here, and he is a critical care physician, EM physician as well, in the Northeast United States. And you probably heard of him. He's Insta famous, isn't that right? So
I mean, that's the only level of fame I'll ever achieve, so I'll take it.
well, we really appreciate all the contributions you do to crit care and EM, and we love your content. And it's one of those things that relationships that buds in the message boards, right? We message each other first, and we're like, hey, we need to, collaborate on some things, and we invite you on the podcast. And of course, when you invite someone on the podcast, if you're any type of educator, you know that takes 6 months to actually get done. So with everything else going on.
Well, that's on me because it's really an honor to be invited to this podcast. And so I don't know what I've been doing, but just life stuff and summer and all that stuff. But we are here now, and we're ready to drop some bombs on EM board.
There we go. There we go. You're just going to pump up the viewers. People are going to do some, chest bumps, everything. Yeah, we're ready now. So, we don't have a question in this episode, but I thought it would be really great to pick your brain about, we were going back and forth on some topics, and I would say one thing that I talk a lot with colleagues in the emergency department is these just quick hit pearls. And it's so funny because, you can go to ASAP, you can go to SAM or other conferences, and, some critical care doctor walks in and it's always intimidating. And they say, everyone should be doing TE down here, or swans, or everyone should be doing these type of ventilator controls. And, the ER docs are just trying to clear the lobby. They're just trying to do the best they can. So we're not going to be doing that. This will be.
They never see, like, when the intensivist comes downstairs, and I wear both hats, so I can appreciate it, right? But when the intensivist comes downstairs, they don't know can I curse on this? They don't know the poop show that just happened the 45 minutes before that person walks in, when everything is clean, everything is calm, and then they just start openly asking for stuff. It's like, dude, you have no idea what just happened. So,
yes, exactly.
Emergency docs, myself included, can appreciate just how hard it is. And the last thing you want is some scholar coming down and nitpicking your work.
Bingo. Yeah. So we will not be doing that. Don't worry. But instead, we're going to talk about some really low-hanging fruit topics. And I'm going to push on some of these things too, I think. But it'd be great for us to go back and forth, and we'll just take it away. But I think the main thing to focus on is just 5 major crit care pearls that every EM physician should know, no matter where you're working, rural or urban or academic. These are just some massive pearls you can share with your residents, or if you're a resident listening, of course, share it with your attending, politely, of course. There's no good way to do that usually.
And don't, if you're a resident or a fellow, don't go up to your attending and say, hey, I saw this on a blog once. All right, just go at least try to Google search it, or like look at PubMed before you go to the attending. Because
I was listening to a podcast, and it was a free podcast too.
And what you're doing, attending doctor, is completely wrong, because that person on the podcast said it. Yeah,
exactly.
Never a great idea.
Yeah. So why don't we dive in here? What's your first pearl you want to give us? Oh, but first, actually, I always forget to do this. We got to talk about rapid bombs, of course. A plug and shout out to EM Rapid Bombs, to those preparing for their boards. I think you are board certified now, right?
Who, me? I have too many boards. I'm triple boarded.
Yeah, no, I'm saying, how do you keep up with all your board certifications? I get mad just doing mine. But
geez, it's tough. But if there was only a program that could go over high yield emergency medicine tips, that'd be very helpful in my life.
Yes, bingo. EM Rapid Bombs. Check it out. It is really a steal, especially because Netflix just bought Warner Brothers, or they're about to, and they're going to raise their prices probably. So our subscription costs less per month than Netflix already, and you get over 550 questions. We go over the answers that are incorrect. We tell you coaching, which means we walk you through the question. And the best part is we really try to make an effort of telling you what is real life versus the boards. And I think that's so important when you're studying for boards. It's not a time suck where you're like, okay, I spent all this time studying all these random things that are never going to happen in real life, or they're wrong in real life. We really try to make an effort of telling you as a side comment, even, hey, this is for boards, but you're going to do it differently in this case, and if it's in clinical practice. So check it out, emboardbombs.com, and it's like a 2-click sign up. You can pay with Apple Pay. It's pretty awesome, and give it to you there. All right, cool. Let's dive in. So
if you can only offer CME for it, that would be just the most incredible thing. Maybe one day.
Maybe one day. Coming down the pipe, stay tuned. We got exciting things in 2026. Iltafat actually dropped a teaser on Instagram about that when he was on vacation. He did a his own video saying that there may be some activity coming in 2026. So thanks for
Really?
further providing a teaser. It's like the
Of
second
course.
trailer before the movie comes out. It's like
That's
just a
right.
few more clips are
The
shown.
red band trainer. I love it.
Exactly. You got it. Cool. Let's dive in. What's your first pearl? You want to tell us some
So let
emergency
me just
physicians
start
out
off.
there?
Let me just start off by saying all of this.
Please.
This is me as the intensive care doctor coming downstairs with some really low hanging fruit
Yes.
that I see sometimes in the emergency room. Sometimes, you know, sometimes I see these things being done, but these are just little things. This is not nitpicky things. And again, I'm an emergentologist myself, so I can appreciate when I forget to do these things. But the first thing I think that's worth bringing up is when you have a patient who's hypotensive and they're coming in, and let's just say septic shock as a prototypical example, and you give them that fluid bolus, maybe you give them the 30 cc's, they're still hypotensive. The next move that you should do is probably start getting that person some vasopressor so they become normotensive. In other words, what I sometimes see happen is that person gets the 30 cc's per kg and they're still hypotensive. Let's give them some more fluids. And then another hour goes by. Doc, they're still hypotensive. Let's give them some more fluids. And what you wind up doing is you just have this crystalloid hope that the pressure is going to get better rather than saying, you know what, this person is hypotensive. Their organs are being hypoperfused. Their mortality is going up as their end organ dysfunction gets worse. Why don't I start some vasopressors now, get their MAP normal, perfuse the organs, and then we can always give them more fluids afterwards to try and bolus off those vasopressors. So that's the first pearl I just wanted to drop.
And well, obviously, you're going for norepinephrine first line in these patients. Just have to say that. I know most of our listeners know that too. What's your order, without going too down the rabbit hole, of next steps? Let's say you do the norep B and they're still hypotensive, et cetera.
Yeah, I mean, and this is the thing that some people might have already thought in their brain is that, well, vasopressors, that means I'm going to start off with a central line right away when that person hits the door. And the answer is no.
Here's another pearl, free pearl right here.
Yeah, I'm going to drop.
Pearl.
This is like extra. I'm not going to charge you guys for this.
Yeah.
But the thing that you have to remember is there's so much literature now that shows that peripheral vasopressors, specifically with norepinephrine, are very, very safe. There are even ICUs that operate as central line-less ICUs with very high doses of vasopressors. So that norepinephrine that you're starting peripherally, as long as you're starting with a good IV, I say above the elbow, not some peripheral finger vein, and you're monitoring and make sure there's no extravasation, you have no reason not to start vasopressors on that person.
Totally.
And then beyond that, depending on the hospital you work with, and I don't want to make blanket statements, you'll have to determine whether or not you need central lines. The hospitals that have vasopressin as being your second line agent, which I agree should be your second line agent, may require a central line, and then you want to go ahead and do that. So that's, I'll just pause right there, but that would be pearl number one. Give your patients fluids that you think they need, but don't hesitate in getting their MAP back to normal and then continuing your bolus if you think that the person needs more volume to get those vasopressors off.
Totally. Well, let me hit you with a deep question here, to one step further. Some of our listeners are probably thinking about, because I think about it too, and there's a recent study on this also. What are your thoughts on that? Hey, they're finishing close to that third bolus, assuming it's 3 liters, 30 cc per kg or whatever. They're finishing close to that 30 cc per kg. They're obviously hypotensive still. What is your incentive of starting vasopressors earlier or completely waiting for that 30 cc's per kg bolus to finish, assuming it's sepsis we're addressing?
I mean, I get the pressures up as quick as possible.
Sure.
I can't find, if I'm infusing my first liter and I notice that their blood pressure is not getting better, I can't find any reasonable logic in withholding a vasopressor. Like, we'll let them be hypotensive because the 2 other liters are still waiting to go. Get the vasopressors on. It is a fluid also, and get that MAP back to normal and continue on. And there are times that you might have seen where that vasopressor's on, you're giving the bolus, and then it's like, oh, now the MAP is 90. Okay, we can start weaning down the vasopressors. But every minute that goes by where that patient's hypotensive, the kidneys, the gut, the brain, the heart, the rest of the body is not getting perfused well, and I can't find a reasonable explanation for why that's okay.
Perfect. No, I totally agree. So ramp up early as always. That's awesome. Cool.
Absolutely.
I think we covered that pearl pretty well. Oh, and stress dose steroids?
Yeah, if you find yourself getting to the second vasopressor, and typically my point is if you start that second vasopressor, that's when the steroids and the
Totally.
fludrocortisone goes on right away. But again, at that point, you're likely getting a central line on that person. You're going to get a little more aggressive with your resuscitation.
Awesome. Sweet. All right, moving on. What's your next thing?
The next one is something that is, again, I don't want to be too nitpicky, but I think it's important, and that's the use of analgesia post-intubation. I will say that after patients have been intubated over the past few years, I've seen an uptick in this, where previously it was just hanging propofol on patients and no analgesia, and the nurse is coming over saying, I don't know, we're up to like maximum propofol, and the patient's still writhing around, and you look, and there's no analgesia on board. Again, this has been better over the past few years, but the SCCM guidelines, which are our guidelines upstairs for how we sedate and give analgesia to patients, is analogous sedation, meaning front load your analgesia first and then hang up your sedation. Because these patients are intubated, they're laying in bed, there's so many procedures happening to them, they're entitled to be uncomfortable. Even though you may not see them uncomfortable because they have sedation on, they are uncomfortable. So front load with good analgesia. And then what you'll find is that when you start your sedation, you're not on crazy high doses for your patients. But this is not just important in like making the intensivist happy, but this translates to decreased delirium in patients who are upstairs. And delirium is actually linked to the mortality. So it's not just one of those things that's like, oh, they'll be less goofy in a few days. It's like, no, actually, you're saving lives by starting with analgesia first.
What are your go-to agents here? Are you thinking fentanyl or?
Yeah, and this is something where I'm going to give a little bit of leeway to the emergency medicine folks.
Sure.
Typically, what we try to do is we try to keep the analgesia pretty light on patients.
Mm-hmm.
So we'll try to do bolus dosed dosing upstairs. So we'll give like a fentanyl push or a
Cool.
hydromorphone push. I think those are very reasonable choices. They're hemodynamically stable, they're very effective, and they're not long lasting. They don't hang around for a while. But down the ED, where the nurses are running around and they're so busy and they can't sit there and evaluate that individual patient where the ratio's, 1 to 30 down the ED, I think doing a drip in the short term is very reasonable, again, of fentanyl or hydromorphone. And then when they get upstairs, they can transition to those intermittent boluses of analgesia for the patient when they show discomfort.
Totally. Totally. That's awesome. And what would that be in terms of my question to you? And I'm sure some listeners also are thinking, how does that change per patient? So obviously like a post-arrest patient versus hey, I intubated septic shock, pneumonia patient, or cardiogenic shock, or even, SCAPE. And if they failed, the NIPPV or something, I intubate them. What is your, does this change that strategy? Are you saying, hey, everybody follows the same strategy pretty much, analgesia front loaded?
Yeah, anyone that's kind of like, how can someone with SCAPE be uncomfortable? They should just take two fingers right now and then just stick them in the back of their throat and just hold it back there for the duration of the podcast. And we'll come back later and see if they're comfortable. And my point being, just the simple act of putting a tube in someone's
Yeah,
throat
it's
elicits the
awful.
gag reflex. It's very uncomfortable. But
Yeah,
then
awful.
laying in the bed, the hospital stretchers are also very uncomfortable. And then all the other things. So it really doesn't matter what is the person who did a little too much benzo or alcohol and got intubated for airway protection, that person should get analgesia first.
Sure.
Worry a little about your neuroexam, do a good neuroexam before you intubate the patient. But
Yeah,
these are such short acting agents that you can always hold them and do your exam after. But I cannot underscore the importance of keeping patients comfortable. And then what you'll find again is that you only need little bits of sedation on top of that. I've gone down to see consults where the patient's on like 80 of propofol and still writhing around and hypotensive because of so much propofol. And just adding analgesia allows us to come way down on that propofol. Their pressure gets better and they're much more comfortable.
totally. That's awesome. Cool. Let's move on.
All
What you
right,
got
let's
next?
see. Well, on the heels of that is a drug that I really like that I think is making its way into emergency departments, and that's dexmedetomidine. I think
You said
again,
that so effortlessly.
it
Um,
took me
we have a
13 years to say
we
that
have a running
properly.
joke on this podcast that Iltifat is an ESL, and so he struggles with words like that, and we actively make fun of him for it.
Yeah.
And that
Well,
I'll be
don't
honest, English is first language for me, and that is a hard word for me to say, much less
well,
spell it.
that word I can say, okay, don't ask me to say what Kepra is because the residents will
Well,
laugh
that's
at
not
me
too
or
bad.
whatever.
That's not too bad.
Oh, really? Go ahead.
I don't know why Levitier acetam
All right, I feel kind of
rolls
bad
off the
now.
tongue.
Yeah, it rolls off the
Sounds
tongue.
like It's so funny because I'll even say that in the ED accidentally because I'm not a big brand name person, and
Yeah, right.
and then the nurse will be like, "What? Never heard of that drug?" And I'm like, "Well,
Yeah.
it's Keppra," and they're like, "Oh yeah, of course, yeah, Keppra."
Oh yeah. Why don't you just say that?
Just
Yeah.
say
I mean, I cannot say that, but I try to be brand nameless because education and all the good stuff. But
of course, yeah,
I
for all the
just
right
have to in the
reasons.
moment just say Keppra,
That's
just
so
Keppra.
funny.
We'll leave
I
it
know.
at
Talk about a drug company that really played that well. They like really played that well in terms of wanting to keep their brand used as much as possible. Like,
that. Oh
let's throw
yeah.
some letters together. They don't make any sense, and that'll be it.
I wonder if that is like, in like what we don't
Oh,
see
I
in the
think it
public.
is.
Like
I think
it's
it
like a
is.
whole like class on pharmacology
Oh,
naming. It's like make it as complex as possible, but make the trade name just really like,
so let
click.
me let you in a little secret of mine. So, and our listeners. So I've had this dream for like, I don't know, maybe in medical school. I started thinking about. I was like, you know what? If I ever retire from medicine one day earlier than I want to, I want to start a college course on the marketing strategies and behind the scenes of pharmacy commercials. So and the assignments will be watching these drug commercials because when I see them on TV now, I'm like, you can unpack this in so many ways that like are not realistic, but it's in such a fascinating marketing strand of commercialing. But anyway, that's a whole different aside. But it is fascinating how they do the naming and everything in both a good and
The
bad
whole
way.
thing.
But
The
oh, it's
whole
fascinating. Yeah,
psychology behind the commercials
it's
is
fascinating.
outrageous. I love it.
Yeah. Anyway, go ahead. What you're so talking about Precedex? I'll say the brand name. We're not sponsored by them.
Dexmedetomidine, but
Impressive.
that it's one of those things that was on patent for a long time and was very expensive. And so I get it. And the emergency department propofol works just as well. But dexmedetomidine is a really nice drug now that's off patent because it works on so many different levels. So it's a sedative, but the nice thing about it is it doesn't suppress your respiratory drive. So you could use it for patients who are not intubated, who are anxious, and you want to give them some sedation. It doesn't suppress the respiratory center. Even in high doses, it does not hit the respiratory center, unlike things like propofol or benzodiazepines, which can, as we all know. That's one benefit of it. The other thing is it also works on the spinal cord on the pain receptors. And so, in that sense, not only is it an analgesic, although not a potent one, it can augment the analgesic effects of the things that you're doing. So if you have somebody who's, opioid tolerant who comes in and you're like, oh, I'm going to have to give this person like a ton of opioids, it can actually potentiate the effect of opioids on the spinal cord for pain receptors. And so that's a nice thing. And then the last thing that I think more and more urban emergency departments are becoming familiar with is the fact that it actually helps to mitigate withdrawal symptoms. It really
Yeah,
helps with that
totally.
tachycardia, the hypertension, because it's a sympatholytic agent and it really breaks. It's basically like IV clonidine is really what it
Hmm.
is. And so it breaks that sympathetic cycle and can help alleviate all those things. Now, the one thing I will say about that, just really quick, is that there are times I occasionally see it being used for people on alcohol withdrawal in place of benzodiazepines. So in other words, they're benzos, and then they're like, hey, we'll start them on dexmedetomidine. And it's like, oh, I don't have to use any benzos anymore because their vital signs are good.
Or Pheno.
And
Yeah.
or phenobarbital, right? Which is,
Yeah.
yeah, that's my go-to too. But
Same.
my point being is that if you don't give them the benzodiazepines, you're allowing that person to still stay in withdrawal. It'd be like giving someone who's having status rocuronium and saying, "Look, I fixed the seizure."
Yeah, it's
It's the
symptomatic
exact
treatment. Yeah.
exactly. It's like a little bit of
What's a good
seasoning on
pearl?
top of your, so you
Ooh,
have like the person that's
seasoning.
withdrawing, give them benzos, give them the phenobarbital, and then there's
Yeah.
still like a little bit get a little seasoning, like a little
That's
dash
like you have to
of
say bam
salt
when
over
you do
it.
it too, like Emerald.
Well, I do the salt bay. I do like the
Oh, you do that.
dexmedetomidine bay
Okay.
right on top of
Yeah.
the patient. Yeah.
Okay. We're on top of the page.
They get a little wet, but they appreciate it in the end.
It's worth it. Yeah, they're seasoned. All right, what you got
Totally
next?
worth
Hey everyone, that is going to be all for part one of this podcast with Haney and Blake. Hope you're enjoying some of the key pearls that they're dropping for critical care and emergency medicine. We're going to continue this in part two. We don't want these episodes to be too long. Part two is going to be a continuation, and we'll drop that next week. So be on the lookout for it. As always, remember EM Rapid Bombs. You can find that by going to our website, emboardbombs.com, and clicking on that question bank, or you can search for EM Rapid Bombs on Spotify and find it there. That's our premium podcast that's got hundreds of episodes, 3 to 5 minute long episodes that are great for ITE boards and in general, just keeping up to date with emergency medicine. Thanks, everyone.